case 4. A 45-year-old man with a slowly growing thumb nodule. The clinical impression was cyst. Now, I don't know about in France, but in my practice, everything comes in as rule out cyst or rule out lipoma. It's always a cyst or a lipoma until it's not a cyst or a lipoma, until it's some rare sweat gland tumor or sarcoma or any other thing. And so this is a crucial point, maybe not so much for pathologists who already get this, but for our clinical colleagues, or if you teach medical students, I always hammered on this point to my med students. Everything that is a nodule in the deep dermis or subcutis, it doesn't matter what it's made of. If it's a nodule down deep, it will look like a skin-colored lump, bump, nodule, papule that will look identical to a cyst or a lipoma, because those are very common. And usually a skin-colored lump or bump is a cyst or a lipoma, statistically speaking. But every once in a while, it's something else. And I've seen many patients. I volunteer in some rare cancer patient groups on Facebook, like dermatofibrosarcoma protuberans and angiosarcoma. And some of those groups, particularly dermatofibrosarcoma protuberans, many of those patients were misdiagnosed for years as just having a cyst, don't worry about it. And then finally someone did a biopsy once it starts, fungating out of the skin, and of course it was sarcoma. So I think it's important for our colleagues to know the only way to really know something's a cyst is to biopsy or excise it and let us take a look microscopically. So that's kind of a point that I feel very deeply about. So, well, it is cystic, but it's not a regular cyst, right? It's not an epidermoid or follicular cyst or pilar cyst. It's something else. So we have a somewhat fragmented specimen, and this is often the case in lesions that are removed from the acral soft tissue or skin, from the digits, the hands, and the feet. And I think part of that is because of how close all of the tissue planes are here. Skin and fascia, tendon sheath, tendon, ligament, synovium, bone, periosteum, all present within 1 centimeter of each other in your fingers and toes. And because of that, tumors that grow in those sites are often difficult to remove in a nice compact fashion. And I think also hand surgeons and foot surgeons, they are cautious to not damage normal structures. So I think they use more blunt dissection and pull, which is appropriate, I think. So because of that, when you see a nodule of something that has no fat around it, no skin over it, has some kind of tendon-like connective tissue, and it's kind of fragmented or ripped at the edges, usually that's a clue that you're probably dealing with something from the hands or the feet. So that can be helpful sometimes. So here we have both cystic areas and also dense hypercellular areas from low power. If we go in closer, whoa. Excusez-moi. All right. We can see that in some areas the cyst is lined by papillary or micropapillary structures, little fingers of cells protruding out into the cyst lumen. Some of them, of course, like with other micropapillary things, will break off or be tangentially sectioned, so you just see little floating islands without any, in this case, without any fibrovascular core. The cells are relatively uniform and bland. I think in some areas on this particular case, there was more atypia and mitotic activity. But at first glance, even though the case is hyperchromatic, a part of that is due to the H&E on this particular case. I remember the lab that did this had a kind of darker hematoxylin and eosin stain. So that's one thing that my dermatopathology mentor, Dr. Douglas Parker from Emory, he taught me when I was a fellow that when you're looking at a difficult case from an outside laboratory, like as a consult, try to get the block and do your own H&E stain. It's not that the outside H&E is wrong or bad, but it's different than what you're used to and what your threshold is set at diagnostically. So it can be helpful to see it on your home soil, so to speak, right? In your native laboratory, and looking at it under those conditions. And I have found that to be useful sometimes. So there's a little tip. So we have little papillae and micropapillae, cystic spaces. Let's go look at the cellular component. Oh, it's upside down now, I realize. So the cellular area is kind of looks like a cyst, but filled in with sheets of these cells. In some areas, the sheets are totally solid, round, or oval nuclei. Here you start to see some mitotic activity, but relatively uniform nuclear size and shape. But in other areas, we see this, and this I think is very helpful. We see ducts or tubules, right? Lumens, nice duct lumens. And here we don't really see the cuticle so much like we saw in those sweat ducts in the microcystic adenocarcinoma, but we see that the lining see how it has its own lining. There's the basal layer out here. And look at this kind of columnar lining that lines each of the tubule spaces. I find that pretty characteristic in this entity. See right here? See how that duct right there, it has its own little lining of cells that all are oriented towards the duct lumen. And those tubules are punctuated, kind of scattered in the midst of this solid sheet of cells. So this combination of features, solid sheets with tubules, cystic spaces, and papillary structures of varying size and shape on an acral surface is the characteristic findings of digital papillary adenocarcinoma. It used to be called aggressive digital papillary adenocarcinoma, but over time they've dropped the aggressive part of the name because it is a malignancy, but it's not that much more aggressive than a lot of other adenocarcinomas. So the current tendency is to just call these digital papillary adenocarcinoma. These are relatively rare, but they are not well recognized by many pathologists. So it is a dangerous pitfall. This one did have some areas with atypia, but much of the tumor was relatively bland cytologically. And I feel like I've seen quite a few of these now. The majority that I have seen did not look cytologically malignant. They looked cytologically benign, but they're malignant by nature of having the papillary structures and the cystic spaces and being usually in the digits, like the thumb is a good site, but the digits, hands, or sometimes feet, usually in a middle-aged adult, and they're more common in men, although they can occur in women as well. So those findings together are what are diagnostic of this tumor. So they're important to know that anytime I see what I think is a sweat gland tumor with any cystic change, or even without cystic change, and I'm in the digits, I always stop and think, could this be digital papillary adenocarcinoma? There are some times where they don't have well-formed papillae. There are some cases that are totally solid and don't have cystic spaces. And the other difficulty is that sometimes hydradenomas, which are benign and can arise in the hands and feet, can have areas that look similar to this. And I have struggled with that before. And the difference is pretty big because I can't remember, it's 20 or 25% of these will eventually metastasize either to the regional lymph nodes or to the lungs. So these are tumors that can be very bland and deceptively benign and yet have the potential for fatal outcome to the patient. And when they're treated, they sometimes will have a tendency to recur, which may result in an amputation of a digit or a ray amputation involving part of the hand. So you don't want to be wrong. You don't want to miss this, but you don't want to overdiagnose it because it may result in overly aggressive treatment, okay? And I think it's a rare tumor, but it is out there and it's good to know about. So I just make a rule for myself. Anything that I think looks like sweat gland tumor, making a nodule in the hands and feet, I always stop and think, maybe could it be that? And then try to prove that it's something else to make sure that I don't miss this rare pitfall. It's a good thing to do for rare pitfalls because they're things that are not on the top of our mind. So when there's something we know is a rare thing but a very dangerous mimic, I just like, if I think it looks like a rheumatoid nodule, I always ask myself, could it be epithelioid sarcoma? Because they're rare, but they're bad. And I know that they can mimic rheumatoid nodules, so I ask myself as a habit every time in my head, could it be? No, it's fine. And then I move to the next case. But if you don't teach yourself to ask those questions, there's a potential that you will go past it and not think of it because it's an uncommon thing. Okay, so this is a very good example, very classic example. And I think most of them that I've seen are nodules like this down in the deep dermis or subcutis or even at the tendon sheath level, but I have rarely seen them present in the dermis actually and have an infiltrative growth pattern, but I think that's much less common. Usually they look like this. They may have infiltration at the edge or they may be very well circumscribed, and just remember that they are not always malignant in appearance. I personally don't find immunohistochemistry to be terribly helpful here in discriminating it, but some people do occasionally use immunostains in this context. I don't have a great familiarity with which stains people like, but I think I've also noticed, oh yeah, that's what I meant to tell you. Not always, but some cases have this kind of squamoid world, almost like the morules, that you see in endometrial carcinomas, right? Sometimes get those world squamoid areas. Sometimes you can see that in this tumor. I think that's a very useful clue, but is not always present. So these are important tumors to know about and rare, but potentially a very big problem for the patient. So that is digital papillary adenocarcinoma. Any questions about that?
The treatment is difficult.
Yes, it is. And I think that there's been some literature that talks about amputation. So some surgeons seem to want to go straight to amputation. It's my personal view, having worked with a handful of different doctors who have treated these, I think it's reasonable to try to excise with negative margins and spare the digit and follow the patient. They're so rare, I don't know if there's a good prospective study comparing that versus amputation. So I think that's the problem with rare tumors like this. We don't always know what to do. Different people do different things, but there's not good evidence or proof in a large sample size because they're so rare.
Is there an adenoma?
Well, the question is the papillary component the distinguishing feature to exclude a cystic hydradenoma? I think in general, yes, that's the most helpful feature because hydradenomas don't usually have these kinds of structures, like real nice micropapillary structures, but sometimes they can have areas that protrude into the cystic space and look papillary. And in the past, they tried for a while, long ago, to sort out digital papillary adenomas from adenocarcinomas, to say if they look malignant, we'll call them adenocarcinoma. If they're cytologically benign, we'll call them adenoma. And then it turned out that pretty much all of the papillary appearing tumors like this, regardless of cytologic atypia, had a potential for metastasis, which is why they're now lumped all together under adenocarcinoma. But I have to admit, I still find it a real struggle sometimes to tell these apart from hydradenoma. And I had a case not that long ago in the past where I thought it was a papillary adenocarcinoma. And I had colleagues who thought that too, but we sent it for an expert consultation, and the expert said that they thought it was a hydradenoma. I don't know for sure what the outcome was in that case, but I still feel worried about that and told the surgeon that I want them to closely follow that patient and ideally try to get a negative margin if they can, because I feel very worried about anything that has any papillary appearance when it's in the digits, because I'm afraid of missing one of these. Any other questions or comments? That's good. Thank you for that. The point was made by Dr. Corina Socha,
Yeah.
right? That there have been papers that describe that resection with clean margins versus amputation, the metastatic risks seem to be the same, and it was around 20%. So I wonder if that was the MD Anderson group paper. They published a large series on this, but there have been others, and I've not read all of the papers on this. So, but I think that's good to know, and that's been my approach. And I also think a good thing in any of the malignant sweat gland tumors, particularly in the hands and feet, but even in the extremities, I often recommend to my dermatology colleagues that they get either hands surgery or just orthopedic oncology involved. So orthopedic oncology is the term in the United States that we use for orthopedic surgeons who specialize in bone and soft tissue malignancies like sarcoma. So even though these tumors are not sarcomas, there are a lot of similar features in regards to surgical management, right? To remove a tumor with a negative margin on the extremity without compromising the neurovascular structures. And sarcoma surgeons are experts at doing that. They remove large malignancies from the extremities every day. So I have found, and in my practice, I've actually recommended a lot of times to consult with sarcoma surgeons when dealing with a malignant adnexal tumor on the extremity, or even really bad large squamous cell carcinomas, because I feel like they're very familiar with how to do that surgical approach, even though biologically these are different tumors. So usually when one of my sarcoma surgery colleagues is seeing a squamous cell carcinoma, that means it's really bad. So, but I found that they often have a lot of value to add, and the same for hand and foot surgeons. So I think it's good to have that team-based approach and to discuss these patients at multidisciplinary tumor board and to bring different viewpoints into the discussion in crafting the best approach for patient care. And I feel that's obviously, I'm sure that you do many multidisciplinary tumor boards here. I found that to be a wonderful way, especially for rare diseases, to come up with the best strategic approach for managing the patients. I learn a lot from attending those conferences, and occasionally I'm able to bring up literature or input from my experience that comes into the discussion, and I love getting to participate in patient care in that way.